Okay, good afternoon, everyone. This is Debbie Melnick, and this is the March 22nd meeting of VCSQI's Opioid Management Workgroup. Thank you all for joining, and for those who join later or listen to this at a later point in time. Again, please make your presence known either on the phone or in the chat box that you can locate the bottom part of the screen. And also feel free to use the chat box to enter comments, ask questions, whenever you feel the need to comment. Whoops. So just by way of reminder of the objectives of this work group, they're listed at the top of the agenda, now labeled minutes, to commit to review opioid prescribing practices within each of your practices, to review, understand, and adapt tools already available toward improving your prescribing practices, to implement an opioid prescribing protocol in your practice, and encourage clinicians to take the pledge, and there's a link there for that, and to share resources and learn from each other. Appendix B continues to be a listing of various resources. With this agenda also came a Word document that kind of mimics the template being used across the country in the TCPI project. If you believe you have a story to tell about how you're better managing prescribing of opioids, you can use this to sort of get started, but ultimately you want to do it online, and we're happy to help you with that. All right, any other agenda items that anyone who's joined on would like to add? You can put it in the chat box or speak up. Okay, and we will continue on. I wanted to share some high points from presentations that were made last week at the VCSQI quarterly meeting. This is like the original VCSQI that has had members in the Commonwealth, from the Commonwealth of Virginia for over 20 years now. And there's a quarterly meeting, often with outside speakers. So last week we had two speakers, Dr. Allison Bryan and Dr. Mark Huntoon, and they were speaking specifically about the opioid crisis in Virginia as well as across the country. So the link here will take you to both of their slide decks, and probably within a week or so, the actual recordings of their presentations will also be available on the website. So I just wanted to make a couple highlights. I don't know if any of you have had a chance to look at these slides. I'm not going to open that up and go through them, but I just wanted to highlight a couple things that they each said. Dr. Allison Bryan is the Chief Deputy of the Department of Healthcare Professionals for the Virginia Board of Medicine, and she led the effort there to create the new regulations associated with prescribing opioids and buprenorphine. Indicating that we, meaning prescribers, are very much a part of the problem. In the 1960s, 80% of first opioid use was heroin. In the 1990s, 80% of first opioid use is a prescription drug. The US uses 80% of the world's opiates for 5% of the world's population. 11% of high school seniors report non-medical use of prescription opioids. And drug overdose is the leading cause of death in the US between 25 and 45 years of age. So I think we've heard some of these numbers before, but again, it's pretty alarming. She reviewed regulations associated with acute pain, highlighting key concepts that an appropriate history and assessment of the patient's history and risk is important. 7-day limits is also recommended for post-surgical pain. She had about 3 slides on key concepts for acute pain. As you will guess, she also listed key concepts in the regulations for chronic pain use, indicating an initial evaluation. Again, the use of urine drug screens, checking with the prescription monitoring program in the state, assessing the risk of substance abuse, considering, the actual dose and the morphine milligram equivalents that you're using. So all of these things were reviewed by her as they are included in the new Virginia regulations. She also encouraged everyone to check the performance monitoring program. She outlined how that happens in Virginia, but most states now have one. So again, you might want to look into how your state's PMP can be accessed. And then one of her slides was specific to Virginia. She described that since these regulations took effect, the number of individuals receiving a prescription for an opioid has dropped by about 30%, and the number of doses of opioids prescribed has decreased about 40%. However, the number of deaths from opioid overdose continues to increase. On that point, then she launched into talking about buprenorphine prescribing for addiction and how some of those regulations have changed. Virginia's regulations are some of the first across the country. She made the point also that these are not intended to stop prescribers from using opioids, but rather to guide them in their determination for when to prescribe, how to prescribe, and follow-up monitoring. So that's a good, that was a good intro to the issue last Thursday when we all met. Her presentation was followed by Dr. Mark Huntoon, professor of anesthesiology and section head for regional anesthesia and pain at Virginia Commonwealth University Health. He has also worked at Mayo Clinic and Vanderbilt in this capacity, and is the editor of the Regional Anesthesia and Pain Medicine Journal. So he's been around this block of pain management and the opioid crisis for quite a while, and I think really made some strong statements about what works and what doesn't work. He talked about which chronic pain patients are at risk for persistent pain, and then also reviewed how to prescribe, not only for chronic, but for surgical patients. He reviewed several research findings that were quite interesting, a couple of them noting that the use of opioids post-op doesn't really help in the long run and can continue with the experience of pain, can continue the pain rather than actually address it. He talked about efficacy and safety of opioids in older patients, about opioid-induced hyperalgesia, which is the tolerance to opioid that occurs over time, requiring more drug to maintain the effect, and requiring alternate treatments with cessation because the opioid is worsening pain. So in his presentation, for those of you who come from surgical practices, he did, as I started to say, mention the use of opioids post-op and alternatives that might be a better first try at helping with pain. He made a point also of talking about the difficult conversations, that's what they're called, that occur between the prescriber and patient around either the initial use of opioids or the discontinuing use and tapering off. He noted a website, this is based from Oregon, or it's www.oregonpainguidance.org/resources/difficult-conversations. This shows up on his slide number 23. Really making a point that it's important to have these conversations with patients and to do it so in a compassionate way that continues the relationship but helps wean the patient off of opioids. Important to our topic today, he emphasized the need to assess a patient's risk for addiction and did use as the very first example he put up, the one that is in the link in the next agenda item, This is the tool developed by Webster, and it is a very quick way. It's a validated tool to assess your patient's risk of addiction. He also referred to the SOAP version, Screener and Opioid Assessment for Patients with Pain. So I would encourage you to, at a minimum, look through these slides, and then in the next couple of weeks, the actual recording of both Dr. Allison Bryan's and Dr. Huntoon's presentations will be available. I just asked my colleagues, Eddie and Ivan, I know you're both on. Did you want to add anything about the impact of these presentations and how they left you thinking and feeling for what we're doing today with all of our practices? Today in general, not right this minute.
This is Ivan. I will say that they, the one impact that the second speaker, pain management specialist, left on me was how in charge he felt of the situation and how in control he felt. And a lot of times when I talk to practices, they feel as though they're doing their best, they're doing what they know how to do, they're doing what they've been taught to do, but they don't feel as in control. And it was interesting just to watch him speak and field questions, but there was just a certain level of confidence that he had that I would really like for a speaker like him to be able to share and spend time with other practices and providers for them to learn from him.
Eddie, any comments?
Thanks, Debbie. Yeah, I guess just the one comment would be, did you mention our work with starting up an initiative with STS?
That's later.
Opioid prescription.
Yeah, later on as an update, but go ahead.
Okay, didn't want to do a spoiler alert here, but essentially we wanted to invite Dr. Huntoon to be part of that group too, as well as any members of this work group too, I think.
Right. Thank you. Jana, you were there as well.
I think what impressed me was when the pain management specialist said that taking opioids can actually cause more long-term pain, as a short-term help. And one of his other comments was that if you give someone a placebo and you tell them it's going to help, it helps. If you give someone pain medicine, say, I don't think that it was going to help, but we can try this, that it doesn't help. So I thought the psychology of communication is really important in the prescribing practices.
Jennifer, I think you were there as well. Jennifer Whaley, did you have any reactions you want to share with the group? I know I'm putting you on the hot seat here. You might be on mute if you are talking.
Or we can call on Beth too. I know Beth always has some insights to share.
I'm sorry, I was on mute. I didn't realize that.
Go ahead, Jennifer.
Hey.
And then we'll ask Beth as well.
I just went off and said all this stuff, and you're like, hello, hello. I'm like, oh. Yeah, I was there. I thought it was a good presentation. The thing that I would have preferred from it, though, for a takeaway is for providers who do prescribing, there wasn't a lot of assistance or input or guidance for alternatives. It's just like, here's this, you probably shouldn't, good luck to you. And I was like, oh, well, okay, good insight, but not really helpful for me to have anything applicable to my practice.
Okay. Yeah, I think he did offer a couple of do's and don'ts, but maybe not quite as specific as you were looking for.
Not as helpful as I was hoping for.
Yeah. Beth?
Yes, ma'am. Excuse me. I listened to the presentation and I tried to apply it to real life scenario. I was bitten by a snake, and the differences between Dilaudid and morphine didn't matter to me as long as it took the pain away. One medication had antihistamine effect. That was Dilaudid. I was taken off of that, and I think that was to try to get me down off of the medications that could be more addictive or to decrease whatever, but I can tell you that it increased edema and they had to put me back on it. And I will tell you, if someone tried to come in and give me distracting sort of thing or a therapeutic touch, that would not have been greeted well. So for an emergent issue, I don't know necessarily, or post-operatively, if that would go over hugely. I don't know that it would. Do I think that some of these medications, absolutely, we need to trim it back. I think decreasing the amount that we're giving is optimal. But do I think that it is effective and well utilized for people that have it? Yeah. I work here in the office with a nurse who's working in the OR. She had a terrible fracture of her arm. Yeah, I would love to see someone come give her therapeutic touch. No. So I don't know. There are some things that I'm afraid are a little bit, I don't know. I don't know. I would like to see, like the previous person who spoke, maybe some additional suggestions, but I can tell you from 20 plus years at the bedside, I don't see a lot of those things working. We used to give medications IV, like we have an IV form of acetaminophen now that we're giving. And previously we had an IV like an IV form of Motrin, if you will. That was wonderful, but we can't use that anymore. So are there things that we can use as alternatives? Most certainly. I think we're doing very well here at Mary Washington. We give Ultram. For some people, that makes us, made me, for my spinal surgery, makes me feel loopy between that and muscle relaxants. But were they effective? Yeah, they do help me. They just leave me in a fog for 2 days, so I can only take them on the weekend. So are there additional things we can be doing? Most certainly, but I think we need more guidance, and we need to know what most certainly will work. I know everybody's an individual, and we have to treat everyone individually. We also have to figure in HCAPs. So I'm interested to see what is successful with other hospitals.
Okay, thank you, Beth. Including the pain management question in their analysis of how well a hospital does with patient experience. I think the question remains in HCAPs, and in some hospitals, leaders' bonuses, that was actually talked about last week too, factoring in pain management. But hopefully we're starting to see the end of the use of that measure for financial gain. Dave Sugru, I don't know if I said your last name right. Dave's a clinical pharmacist from Carillion. This is the first time he's joined our group. Were you at that meeting last week?
I was not there, no.
Okay, any reaction to what you're hearing?
Well, just from scanning all of the minutes and kind of the comments of what was said at that last presentation, I'm curious as how we can start applying a lot of the data that's from chronic pain to our acute pain kind of practices. Because, the guidelines and everything that's been presented, it's all extrapolated from chronic pain patients. And I think acute on chronic is really where the question mark is. So I don't know. I was excited to join this group just to kind of see what y'all are all thinking, to kind of help boil it down to our practice sites.
Okay. All right. Thank you. Hopefully we'll get to more of those discussions as well. Steve Dixon, I know you were not at that meeting last week, but do you have any thoughts about people who were there?
No, I've been listening to it. We're continuing to work our project down here with Florida Hospital, and we're looking at addressing the acute pain as well as what you have been discussing. So we're still working on it. I appreciate all the comments. All
right. Yeah, if any of you are looking for a speaker Both of these individuals are happy to speak, outside of Virginia, so we could put you in touch with them. Although I think their contact information is on the slides as well. Okay, so then let's move on then to the next item, assessing the patient's risk for addiction. And I'm going to open up this tool, which I've sent to you in the past. It's also on the website. I think this is the one that, as I've scrolled things on the internet, this is the tool that comes up the most often as one that's been validated and helpful for use. We talked about how it, as well as a, no, actually, I think that was more of a signed agreement. But this tool is pretty straightforward. Let's see if I can get to the second page. Right off the bat, you first clearly know whether you're dealing with a male or female patient, and you can see the points that are associated with their answers. Yes answers generate these points. So the scoring a 3 or lower indicates low risk for future abuse, 4 to 7 moderate, and more than 8 is high use. So you can see there are some questions that, just 2 or 3 yeses to some of these questions and you're at high risk already. What do you do with this? As you prescribe, that's something that I think each prescriber determines. Are they going to say, nope, you're not getting one? Are they going to try something else first? Are they going to enter into a prescribing regime more carefully with more frequent monitoring, lower doses? It's intended to be a way to evaluate the patient in front of you and how to proceed with their pain management program. So I was hoping to actually have identified one of our practices that would speak specifically to what they are doing to assess patient risk, but that didn't quite happen in time. So just wanted to open it up for discussion and see if any of you are willing to talk about a process that you know is occurring within your practice or at the hospitals where your clinicians practice at when it relates to assessing the patient's addiction risk. Whoops, any of you like to speak up? Have any of you used this tool? Let's start there.
So this is Jennifer again. We don't use any screening tool specifically, especially to identify whether or not they're at risk of additional addiction after surgery or discharge. But one of the things that we've done is part of our preoperative assessment is we go through a few questions about history of addiction, misuse, abuse, or suicide. So our nurse practitioners just ask if they've ever used, street drugs, if they drink alcohol, how much. They just kind of do an already assessment of abuse risk. Have you ever had a history of suicide, ever been committed to a mental institution, or seen by psychiatry for a mental illness?
Okay.
But we don't screening tools specifically.
How are the, if those answers are yes, do you know that it affects what happens next?
It doesn't affect our prescribing for treating their pain. We still treat their pain, but we do more counseling at discharge about the need to use Narcan. And they get their prescription for Narcan if they have a history of that, just in case they decide to overdose or abuse what they're given at discharge for their pain. They might not die from it.
Okay.
But that's the only thing we do for them. We still treat their pain and send them home with pain medicine just like everybody else, because we just did surgery and that's not nice.
Yeah. And actually you bring up a good point. There was some discussion last week at that meeting, as you well know, about the need to also prescribe Narcan to patients who are at risk.
Yes, that's the only difference for these people. everybody else that we send home with pain medicine, as long as they're not over a certain morphine milliequivalent or not taking a sleeping pill or any other kind of benzo along with it, you don't go home with Narcan. If you are taking other medication, if you're taking, muscle relaxers or benzos or sleeping pills, and you're getting an opioid prescription at discharge, they always get Narcan. But the people who answer, they have a history of overdose or, drug addiction or suicide, any of the things that we ask them before surgery, all of those patients get Narcan.
Okay. Would anyone else like to offer what they're doing or what they think they might start doing in terms of assessing risk?
Hey, this is Dave. I kind of had a question for, I think, is it Jen? I apologize, I got that name wrong, for Whaley. We at Carillion don't have a specific tool that we use for screening. I think some of those questions for alcohol abuse or drug abuse are asked just in terms of an initial health screening, but we don't necessarily apply it in terms of how we're going to manage prescribing on discharge. We do factor that in for like the acute pain period where we change our strategy sometimes. Jen, do you guys, so based off what you say, is that anyone with a history or concurrent meds that might be like additive for respiratory depression, what percentage of patients do you think you're sending home with Narcan? Because I feel like that'd be a lot of our patients.
We send home, I would say, a third of our patients have Narcan, at least, either because they answered their questions like they have a history, or if it's something else on their medication list that they have access to at home.
Cool, thank you.
We give them a Narcan prescription, and we have a patient handout that we give them that talks about when, why, and how to use it. And then our pharmacy provided us with like a quick resource with pictures to demonstrate how the delivery of the medication works, so that they don't fumble through it if they actually need to use it.
Do you require like a family member be there with them when they get the information?
No.
No. All right, thank you for sharing. Appreciate it.
You're welcome.
I think Dave asked, do you require a family member to be there as well as you're teaching it? Is that what you asked, Dave?
Yeah, just because I know sometimes when I've had conversations about naloxone, it's difficult for that person to interpret like how they're going to administer it if they are the one with respiratory depression. And so I usually try to grab like a friend or family member, but that was more when I was working in the ED. We have not been sending people home with naloxone, and I kind of see that being something that we can work on in the future.
Are you still there, Jen?
Yes, I am. Do you have a question?
Well, you make a good point. Oh, go ahead. So do you include the family also in that discharge counseling?
We don't make it a point to do it. Like, I'm not going to say, okay, I'll come back when a person is here. But if a family member is there, they get the teaching as well when I go over it with them. But then the patient isn't allowed to be discharged until a person is there with them, and the nurse goes over all of the instructions with the patient and family.
Okay.
So the teaching is done by the nurse. The provider specifically will do the teaching with the Narcan when I happen to be in the room to go over it. Whether a person's there or not, okay, I don't care. But then the nurse does it again, all of the discharge instructions, to include that.
Okay. That makes sense. Beth, does Mary Washington do anything in particular, or the providers in the practice with risk assessment?
I'm not so sure about risk assessment. I know that they're looking at it. I'm looking at most of the charts. I'm not over with the CV surgical team. I'm over in the quality department, so I'm looking retrospectively. But I can say of the patients that are reviewed, there are patients that in some cases are going home with Percocet or Norco, depending on, you know, which person is sending your medications to you. But same sort of drug, or they'll go home sometimes with Ultram. And I have seen a couple of instances where patients have gone home with Narcan. So they are covering the bases. We have a nurse navigator here that does do instruction. They have instruction before surgery. They have videos and so forth. They're visited by the navigator during their visitation here. And then during that time, they are given additional education, and that normally does include the family at the bedside, if there is any.
Okay. Well, it might be useful to share. You're the quality person, Beth, you said? Mary Washington?
I am in the quality department.
Yeah, it might be useful to share that opioid risk assessment tool with the appropriate people and with the surgical practices there.
Yes, Mike Brown is the chief of perfusion here, and he was there at the meeting, so he has seen it, and okay. I'm happy to print it out and give it to the surgeons and to the mid-levels. But he essentially is the head of the cardiovascular surgical program. He kind of oversees everything, so he's seen it and isn't aware.
Okay. Steve, is this a tool that you're all looking at in the work that you're doing down in Orlando?
No, I have not seen that. I'd like to see that. Yeah.
Okay. Yeah, it's pretty straightforward, pretty easy to tabulate numbers and identify which patients are at risk. So it might be something that all of you, not just Steve, you as you're looking at your protein management plan, you know, as part of the pain management plan, to understand what to avoid and what to monitor perhaps more closely going forward. Anybody else have any comments? Any of my colleagues from VCSQI?
Debbie, I have one comment. One thing, if I go back to what struck me about the presentation, was that the inclusion of things like IBS, Crohn's disease, and the third one, ulcerative colitis, as being significant risk factors. And that's something I hadn't really thought about before. That struck me during the presentation. Something that maybe we don't too often pay attention to in the assessment phase.
Patients at chronic risk, at risk for chronic pain. Yeah.
Correct.
Which makes them potentially at risk for seeking, medications that help them address it. Yeah. I don't think that was on the tool, though, was it?
It wasn't on the tool. It came up during the presentation, but yeah. I don't think it was spelled out on the tool. But it's a good discussion item.
Again, come on, open up. Oh, there it was. No, it's interesting when you look at this, there's nothing on it related to chronic disease. So if you were to throw in a chronic disease as those listed on Dr. Huntoon's slide 3, I don't know, I guess maybe chronic disease is not a risk factor.
Perhaps.
They're at risk. All right. Well, I encourage you to all take a look at B, and you might want to just bring this out at one of your staff meetings to think about how it could be used with your patients, both those who are acute as well as chronic. Scrolling down. Okay, April 28th is Take Back Day. We just wanted to bring this to your attention. Thank you, Jana, for finding this. You might want to post this in offices, or at least encourage patients who you know might have extra pills lying around. This is the Department of the DEA's Take Back Day, April 28th. And if you click here, so hold on to this link and the agenda, you can actually search. I'm going to put my zip code in to determine where there might be a drop-off spot close to you. So here I've got 3 not far from me if I had drugs I wanted to dispose of. Pretty easy. Something you can do and post, you know, the exact locations in your office settings. We talked about this briefly last week. I asked Dr. Huntoon if it was important to also communicate to patients how to dispose of drugs. And of course they agreed, or disposed of down the toilet. They get into, in that case, they get into the water system. I'm sorry, I guess I'm breaking up a little bit. So this is a great date and opportunity to communicate to your patients. Or if they bring them to you, someone from your office can go dispose of them here. So I just wanted to draw that to your attention as well. April 28th, Take Back Day. Wanted to point out a few more opioid-related measures. The ones we talked about last time are the ones that currently are included in the MIPS Quality Payment Program. Remember, they're the ones that ask, do you do a risk assessment? Do monitoring measures that are collectible through claims. They are only on the Prime registry, which if you're not part of that, it's very difficult for you to select any one of those 3 as your MIPS measures for 2018. Although I wouldn't be surprised if they become added to that. In either case, whether for MIPS or not, here are 3 measures to think about. The use of opioids at high dose in persons without cancer, the use of opioids from multiple providers and at high dose in persons, I think that's without cancer, and the use of opioids from multiple providers based. So reading the details of them would be important as you consider what these mean and whether or not, you know, your practice might use them. I just wanted to point them out and share, you know, that there are measures coming out more and more that relate to this crisis. Updates. As Eddie alluded to, we continue to be in touch with the Society of Thoracic Surgeons to establish a work group that probably will end up writing 2 position papers. It's hard to know right now until we get into the details. One would focus on recommendations for prescribing opioids with cardiothoracic surgical patients. The others would focus on thoracic surgical patients. There may be the need for two. It might be possible that one paper addresses both. We are still interested in whether any of you are potentially interested in serving on that work group. I know 4 nurse practitioners from the original VCSQI members have already expressed their interest. STS, of course, will identify some individuals yet. We're still at the table. We hope to circulate information and draft material to all of the CT surgical practices in our TCPI and in the original VCSQI group. So you should all have a chance to actually review the material, but there's a very documents like this that come out of the organization, so that process will be followed. So just shoot me an email. Survey that we did in the fall. I wanted to wait till today's meeting so I had a chance to tell people. We're going to cut out some of the questions from the opioid survey. You may recall we did both a PFE, Person and Family Engagement Survey, and one on your opioid prescribing practices. We're going to reduce the number of questions in the opioid prescribing practices survey, but we'll be getting that out probably next week. When we did it in the fall, we did not have nearly the number of enrolled practices. A higher number of practices now responding, and we'll get a feel for where everyone is and continue to use these surveys as opioid prescribing and person and family agenda and set of minutes. If you have a story to tell, link to the actual online data entry point if you want to go straight. Share with everyone. I think I am off. Hello?
Hey, Debbie.
Okay, I'm back.
I can still hear you.
Can everyone hear me now?
This is Ivan. I can.
Yes, I can.
All right, I don't know what happened. Usually my internet connection sitting here, I haven't moved, it's fine.
I can hear you better than before.
So that probably means I lost the recording and all. I don't know. Does anyone have anything else they want to add? I will type in what I said in the minutes. Can somebody tell me you hear me?
I hear you, Debbie. This is Jana.
Okay.
You were faded in and out, but you've been continually connected, and it looks like you're still recording, although the clarity might be limited.
Okay. All right, so next meeting, April 26th, we'll talk a little bit more then about securing and documenting a patient's treatment agreement. What that means, when you might want to do it, what happens if the patient violates it, And perhaps one or more of you will have a story to share there with the rest of the group if you're doing this. I'd be interested to hear from you ahead of time so that we can note your story sharing for that agenda. Any other final comments? We're ending a little earlier. Okay, bring along more friends next time to the meeting. Let's keep these conversations lively. Thank you all for sharing what you were able to, and have a good rest of the week and a nice spring break if you are having one soon, which most people are off or at work. Have a good spring break. Thanks, everyone.
Thank you, Debbie.